Good evening, all. I welcome everyone on behalf of IRIA Kerala to the case discussion series in association with JournoMed. And last month, actually, we discussed almost all important topics, major topics in genitourinary tract. And this month, that is July, actually, we are moving on to neuroradiology. And for this, I welcome Dr. Gomati Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Shenai, Program Coordinator. And today, the session moderator is Dr. Reshmi. She is consultant radiologist in Anandaburi Hospital and GG Hospital, Trivandrum. And our faculty is Dr. Puneet Keti. He is consultant in interventional neuroradiology, Manipal Hospital. Hearty welcome, Dr. Puneet Keti.
Yes, sir.
And now over to Dr. Reshmi CP, session moderator, for the introduction of the speaker in detail.
Thank you, Venu sir. A very good evening to all. So welcome back to the academic session of Kerala IRI. As Venu sir said, we are moving to CNS, neuroradiology this month. So we are starting, our faculty is Dr. Puneet. He has done his MBBS from Bangalore Medical College and Research Institute, Bangalore. He has done his MD in radiology from the prestigious All India Institute of Medical Science, New Delhi. And he has also done his DM in neuroimaging and interventional neuroradiology from AIMS itself. So that itself speaks that he is an expert in the field. So his expertise include neuroimaging, vascular, and neurointerventions. He is presently working as conventional interventional neuroradiologist in Manipal Hospital, Millers Road, Bangalore. So welcome, Dr. Puneet. And so we are actually lucky to have you here as the first faculty in this neuroimaging series. We have two residents today from Calcutta Medical College, Dr. Narmin and Dr. Arya. I first invite both of them to introduce themselves before the case discussion. Dr. Arya and Dr. Narmin.
Arya and Narmin, introduce yourself.
Good evening. I'm Dr. Arya JS, junior resident from Government Medical College, Calicut.
You can switch on the video.
Please switch on, we can see you. Dr. Arya and Narmin. Just video for a second.
Actually, I don't have a camera.
Okay, Narmin, yourself. Narmin?
Madam, I am...
Yeah, good.
Radiology resident from Government Medical College, Kozhikode.
Okay. Okay, Reshmi, you can continue.
Yeah, so we have final year residents, Dr. Arya and Dr. Narmin, for the case discussion. So what Dr. Puneet is planning to do that he'll be showing his cases and we have the residents for the case discussions. So he'll be guiding the residents through the case discussions. Now over to you, Dr. Puneet.
Yeah, like they have a first case. So I think who has seen this?
Dr. Narmin.
Dr. Nauman. So yeah. Shall I share the screen?
Yes, yes, please.
Yes, sir.
Dr. Narmin, you can actually, after he shares the screen, you can actually start the discussion. So it's up to you.
Okay, ma'am.
Sorry, there is some problem with Dr. Puneet's video. So.
Yeah, my screen. Is
Yes,
it visible?
Yes,
yeah.
It is. You can change that slideshow. Yeah.
Yeah, it's visible.
Yes. Yeah, you can go ahead. Yeah.
So this is the first case. She's a 15-year-old female resident from Bihar, was studying in the 10th standard. So born out of non-consanguineous marriage. So her complaints includes poor scholastic performance since childhood. So, and recent history of seizures is 4 months. So on
Should I read?
neurological
Yeah,
examination, on neurological examination, like there are no major deficits involving motor, sensory, and cranial nerves, and even the cognitive performance is good. So on investigations wise, as nerve conduction study, electromyography, visual evoked potentials for a visual pathway, so BERA, which includes the auditory testing pathway, are all normal. So basically, we are looking at a like 15-year-old child with just very mild symptoms of neurological system and with seizures. So when we did our imaging, so this is what we see. So can you describe this? Yeah.
Yes, sir.
Yeah.
Sir,
What you see, you can just go ahead.
I've been provided with selected axial sections of T2 weighted and flare sequence of brain, which shows, in contrast to the clinical picture, there is significant imaging findings here. There is diffuse hyperintensity involving the subcortical white matter with relative sparing of the perirolandic white matter, and also the periventricular white matter is also relatively spared. The T2 hyperintensity involving the subcortical white matter is also involving the subcortical U fibers.
Yes.
In the central white matter appears relatively normal with normal signal in the genu of corpus callosum. The basal ganglia and thalamus also appears relatively normal. There is relative sparing of the white matter tracts in the occipital lobe, and in the cerebellum also appears relatively normal in the posterior fossa. In the flare sequence, in the anterior aspect of temporal lobe, there are few areas which shows suppression. Similarly, in the posterior aspect of parietal lobe also, on the right side, I see areas of suppression which was in a hyperintense on T2 weighted sequence. Also,
Your voice is breaking. Hello, everybody's like.
Yeah, it's breaking. And Narman? Narman, you're there? Yeah, she's there, but I think Narman,
of which is diffusion of diffusion restriction.
Yeah. Yeah. I'll just have a small correction here. So here we can see, these are the caudate and putamen. Do you think they are normal compared to the gray matter? Definitely they are involved. You can see caudate, putamen, as well as globus pallidus element. Thalamus is relatively spared.
Okay.
So now this other point is that when we look here on the T2 weighted images, so basically what we are looking at a bilateral symmetrical abnormality. See, you have one sparing here, it's very characteristic here. The perirolandic white matter is spared here. So you can see here. So this is the rolandic region. So this is spared. So we are looking at basically a diffuse symmetric white matter abnormality. It is confluent, and you can see a predominant sparing of periventricular as well as immediate deep white matter here. So then, so on these sections, you can see, like when we come to the cerebellum, these are the dentate nuclei. These are specifically, both the dentate nuclei are bright. Okay. So now here the thalamus is spared. So the internal capsule is spared and the brainstem is spared, and cerebellar white matter is also spared. So like what you said is right. The temporal lobe, here we can see some of the spaces which are like on the flare, they're suppressed. These are all like VR spaces. So prominent VR spaces. We don't see any abnormality on a diffusion weighted images. So looking at these images, what do you think? So what pathology are you looking at?
It looks like a predominantly disease involving the white matter disease, likely leukodystrophy, in the spectrum of leukodystrophy.
Yes. Okay. So basically you're looking at a disease, it's a leukodystrophy. So with like looking at it, it's a subcortically predominant leukodystrophy. In spite of it, it has a gray matter involvement, a deep gray matter involvement. So how to remember it specifically, it's involving basal ganglia. So both caudate and putamen are involved. So you can see characteristically thalamus is spared. So and even the brainstem is spared. Okay. So I'll come to that why it's like that. Then you have one characteristic finding, perilolandic white matter is also spared here. So another important thing, so this thalamus is spared, you should remember why. So, okay. Now I'll coming to the next part. So these are the T1 weighted images, very small findings, just describe it.
In T1 weighted images, also the sparing of perirolandic white matter is obvious, and the deep periventricular white matter appears normal in the second session slide. And
this is the post contrast image, so you don't see any enhancement.
There is no post contrast enhancement.
Yeah, so this is one spectroscopy. Actually, I have not given you the normal part. It's only taken from the abnormal part. What you can make out is at 135 TE.
In contrast to the diffuse involvement of white matter, there is relative preservation of the NAA peak.
Yeah, so basically, actually, it's a scale. Actually, I should have shown you the good one. The NA peak is preserved, but it's not too much. Actually, according to the normal white matter, what we see. So this is what. So basically, I'll show the summary.
Yes, sir.
So what we are looking at, this is it. So we have bilaterally symmetrical confluent white matter involvement with subcortical predominance. So basically, we're looking with leukodystrophy. So
yes,
this is purely white matter, but we have an additional involvement of gray matter areas, that is caudate, putamen, and of course the dentate nucleus. What we have seen here is pairing of thalamus, brainstem, internal capsule, and cerebral white matter, and no enhancement. So in addition, we have seen some areas of perivascular spaces. So basically now we are looking at a white matter leukodystrophy with subcortical predominance. So what are the differential diagnoses which come to your mind in this case?
Sir, I want to think of megalencephalic leukoencephalopathy with subcortical cysts.
As a first diagnosis? No, just want to know, like there are basically 3 or 4 conditions with subcortical predominance. So that's what. So what are these subcortical predominant leukodystrophies?
Canavan's disease.
Yes.
Then vanishing white matter disorder.
That is not the case. That doesn't start with the subcortical white matter. Anyone? Any others? Any others?
Alexander disease.
No, not start with subcortical. That start with subcortical. Yeah, let me come. Don't worry. So see, this is a very good article actually. So if you want to read about white matter leukodystrophies, the myelination issues, so this is an MRI based approach from Wandernerves. So it's in Neurology 2009. So you can refer to this article. So like it's very well written and very educative. So subcortical, see, basically you have to understand there is gray matter involvement also in this. So, but compared to that, the white matter part is more. And another thing is that you have to remember the patient clinical symptoms are very mild. Okay, so this all adds to the diagnosis in the final. So these are some of the 3 to 4 subcortical predominant diseases. Number 1 is always a Canavan's, should always remember. Second thing is Kern-Sayre syndrome. It's a part of a mitochondrial thing. And the third one is L2-hydroxyglutaric aciduria. So these things can present at this age. The patient age is 13 years. Okay, so the urea cycle disorders and propanic acidemia also have a subcortical, start with a subcortical disease. These are out of equation because they usually present in an infant. So that are not in our case. So what we are left with is the top 3: Canavan's, KSS, L2-hydroxyglutaric aciduria. Have you heard of these names, L2-hydroxyglutaric aciduria and KSS?
I've heard that they have the prominent Sylvian fissure.
Sure. Okay. So like, see, now we have to decide, see, now considering the top 3. Okay. So considering the age, imaging features and clinical features. So we'll be like, we have to differentiate between 3 now, whether it's a Canavan's or if it's in cases or L2-hydroxyglutaric aciduria. So now we look at the imaging. So where all it fits, in what category it fits. So now comes cases. Okay, we have 3 in mind, differential diagnosis in mind. So now come to cases. So what is the clinical presentation of cases? It's usually presents, so basically a severe disease. Presents with ophthalmoplegia, ataxia, retinitis pigmentosa, and art block before 13 years. So we don't have all the symptoms in this. Okay. So then when we look on an imaging, so what it usually see in like somewhere in the middle course of a disease in advanced is the diffuse symmetric calcifications in the basal ganglia. I don't have given you a CT. So okay, if the calcifications are there, you could make out. Second, when you look on an MRI, it's basically a subcortical white matter disease. So apart from this, it involves cerebellar white matter also, the corpus callosum, globus pallidus, brainstem. So all these are there in this case. So we can see except for the brainstem, cerebral white matter. So when the disease is advanced, so any disease can go up to this also, cerebellar white matter and brainstem. So obviously early sparing of periventricular white matter. So diffusion restriction is not there. This depends on the acuity of the disease. So now the history is like somewhat not fitting in this. So imaging plus or minus still, but we don't have a calcification that maybe suppose disease is early in the course may not get this. So still, so I'll show the images. This is how a 29-year-old with KSS will have calcifications in the basal ganglia. So of course it doesn't fit with this. So now look at the MRI. One of the 15-year-old with Cancer syndrome. See, we look at the same like as we shown in my case. This is a subcortical white matter involvement. So when we come to the ganglionic level, you can see caudate and putamen are spared. Even the globus pallidus is spared. The involvement of a thalamus. Usually, most of the cases in this, the thalamus will be involved. In our case, it was specifically spared. And in the brainstem also, we can see brainstem is involved. The dendritic nucleus is also involved. What we are seeing in this is, so we don't see any thalamus involvement in our case, but in cases we have a thalamus and brainstem involvement and clinical features are not fitting. So it should not be of cases. Do you agree?
Yes, sir.
So can now come to the Canavan's. So Canavan's is basically like it has a different presentations like phenotypic presentations. When you present it in an infancy, it's very severe disease. So we usually have a motor symptoms like it involves the along the corticospinal tract. So it will have an hypotonia, spasticity, and it will involve the visual pathway. So and clinically patients will be having macrocephaly. So our patient didn't have. Okay. So basically, when you present it in an infancy, it will be a rapidly progressive disease. So survival is very small. Okay. So anyhow, juvenile forms of Canavan's disease are there. So they can present with mild disease also. But the important thing on imaging in Canavan's, do you know? Can you tell like what differentiates from this? What the case we have seen? This is Canavan's with 4-month-old infant.
It involves the deep white matters also, periventricular white matters, including the corpus callosum.
Yeah, then.
And thalamus will be also be involved.
The important thing in Canavan's is that it specifically involves the globus pallidus. You can see here and thalamus. It spares the caudate and putamen. You can see the caudate and putamen is spared. But in our case, what we saw, I can go back and show. See, this is our case. Here we can see the caudate, putamen are involved. The globus pallidus is also involved. Thalamus is spared. So, but when we go to the Canavan's, here you can see caudate and putamen are spared. Thalamus is involved.
Yes, sir.
And also there are changes in the brainstem and cerebellar white matter. So imaging wise, it's not fitting in Canavan's. The history maybe because the juvenile forms of Canavan's can have this, but we don't. Of course, we don't have a macrocephaly clinically. So somewhat it's not fitting. So what we are left with now? L2-hydroxy glutaric aciduria. So it's by process of exclusion we have come to this. Okay. So why? Like what classical in L2-hydroxy glutaric aciduria is that so patients will have very mild neurological symptoms and imaging features are quite classical in this. There's a subcortical predominance, leukodystrophy. And like, of course, in this case, it was genetically proven. It was a case of L2-hydroxy glutaric aciduria. So today's lesson is we have 3 basically prominent subcortical predominant leukodystrophy. Of course, we have involvement of deep gray matter nuclei. So just I'll describe just about L2-hydroxy glutaric aciduria. So just it's some kind of a new disease. So you must be knowing it. Just it's an autosomal residue disorder. What happens is that it's basically this L2-hydroxyglutarate accumulates in the urine, CSF, and plasma. The thing is that it's a mild, symptoms are very mild actually. So, and it's a slowly progressive disease. So this is one of the good article in radiology, which have described the pattern of imaging abnormalities in 56 patients. I'll show like what have they described. So you can see preferentially white matter abnormalities. Predominantly the subcortical region is predominantly affected. So this is, you can see here, the subcortical predominance in 56 patients, 100%. So when we look here, what is not, is a cerebellar white matter involvement is 0. So in our case, it's also not there. Peduncles were not involved. Pyramidal tracts in brainstem were not involved. Corpus not involved. Internal capsule is not involved. Matter abnormality in our case fits. So you can see subcortical white matter, frontal, temporal, parietal, and occipital. All the white matter areas are involved. It's a diffuse symmetric disease. The important thing is that the sparing of cerebellar white matter, peduncles. So everything is fitting in our case also. So you can see the evolution of disease. You can see is a baby with just 2 months. You can see the white matter involvement in only the subcortical view fibers. At 3 years, the disease progresses and see almost complete involvement of subcortical white matter. So at 11 years, you can see, so it's almost progressing towards the deep white matter. Still, the periventricular rim is spared. So at the 37 years, what we get is atrophy. So you can see the atrophy of the involved white matter as well as overlying gray matter. So when it comes to the gray matter things, you can see there is involvement of caudate, putamen, and globus pallidus in almost all the cases, 100% of the cases. So in our case also, we could see involvement of all this. See, thalamus involvement is very, very rare. It's 7%. So we didn't see in our case. And dentate nucleus involvement, almost like 98%. So here we can see, but when it comes to Canavan's, thalamus and globus pallidus are almost always involved. So we don't see thalamic. The important differentiating point between the Canavans and the L2-hydroxyglutaric aciduria and imaging is thalamus involvement. You can see. So it's very rare. Okay. And dentate nucleus can be there. So here you can see, this is what we saw. This is the case from the article. This is the same abnormality which we could see. You can see the rims. This is the putamen. The rim is more bright in the center. This is what we saw in our case also. Caudate and putamen. This exactly matches this. Okay. So you can see with later course of the disease, there will be definitely atrophy in this region. So this is also the imaging involvement of imaging, which shows the involvement of a dentate nucleus. This is a 3-year-old patient. Disease duration is 3 years. With time, you can see atrophy of the disease. So basically with age, so with the progression of the disease, you will see atrophy of the white matter anywhere, like even in the cerebellar hemisphere also. So then this is what the showing with the later course of the disease. You can see white matter rarefaction also. So to conclude, so L2-hydroxyglutaric aciduria is a distinct imaging pattern which I have described. So this is a subcortical predominant white matter disease, leukodystrophy. Abnormalities also involve dentate nucleus, globus pallidus, putamen, and caudate. So on imaging, so compared to Canavan's disease, there is no involvement of thalamus. That's very, very important. So these are the structures which are always paired in L2-hydroxyglutaric acid, that is internal capsule, corpus callosum, cerebellar white matter, and brainstem. These things are involved in Canavan's disease. So with increasing disease duration, so abnormalities become more diffuse and we'll see atrophy. So hope I think this is understood, I think. Okay. Are you okay? So are you okay with this?
Yes, sir. Yes, sir.
Huh?
Yes, sir.
So basically, whenever we see a subcortical white matter disease predominance, the 3 things that should strike in mind is a Canavan's, L2-hydroxyglutaric aciduria, and Kearns-Array syndrome. It is basically the history, the clinical symptoms. So that will make that will lead to the that will take you forward And on imaging, we have a characteristic set pattern of features which will help to distinguish 3 diseases. So based on this, like we dissected this case and finally come to the conclusion that it's a case of L2-hydroxyglutaric aciduria.
Yes, sir.
So I'll just show, like, hope you got this. I'll just show one more case. It's a periventricular predominance. You should, like I've shared to you, I think
Yes, sir.
you should be having diagnosis in your mind. Can you describe this and just...
Yes, sir. I have been provided few axial sections of MR sections of brain, which shows hyperintensity involving the periventricular white matter predominantly in the posterior aspect of brain involving the parietal lobe. And there is also hyperintensity noted on the lateral aspect of pons and also in the midbrain.
Okay.
So suspecting a leukodystrophy, and the one which typically has a posterior predominance is X-linked adrenoleukodystrophy.
Yeah, nice. So thing is that, so basically when you're looking at a white matter abnormality, see, you have to differentiate between, like, we have entity called hypomyelination, then predominant leukodystrophy. Yeah, dysmyelination. So hypomyelination is nothing decrease, like I'll go to this. Yeah, I skipped that in the initial pattern, went ahead. Actually, I wanted to show them first. Yeah. So when we approach a case, so basically the first discriminator will be hypomyelination versus white matter pathology. White matter pathology is nothing but whether it is a dysmyelination or demyelination. Dysmyelination is nothing but the problems with the myelin formation. Demyelination is just already destruction of an already formed myelin. So first thing we have to, either it's hypomyelination or white matter pathology. Second thing is, when you're sure of it, then if it's a white matter pathology, what kind of an abnormality is? Is it confident, isolated, and multifocal? Then you have to come to the discriminator. Third discriminator will be, what are the pattern of abnormality? Like, is it specifically involving the frontal, parieto-occipital, periventricular, subcortical, or a diffuse cerebral, or is there any particular posterior foci involvement? This is how you approach a white matter pathology. So how an hypomyelination look is different from a white matter pathology. So basically the hypomyelination part, basically decreased formation of myelin. Basically you have to look on a T1 weighted image predominantly. It will be not so much hypo intense as a leukodystrophy or a dysmyelination. So I'll show the images. It's basically it's an hypomyelinating disease. So we have it's a normal 7-year-old child. Here you can see these are the T1 weighted images and T2 weighted images. This is basically an hypomyelination. How it looks on a T1 weighted image. Here you can see it's almost iso-intense to gray matter. Here in the second case also, this is a case of Pelagius Merz-Besser disease. This is a classical hypomyelinating disorder. So here you can see in this case, white matter is hyperintense on T1. When you look on T2, it's not so bright. As we saw in this case, you can see this is a classical white matter pathology. You can call this a dysmyelination and demyelination. On T2, it will be so much bright. On T1, it will be hypo. See, it's hypo and hyper. If it is an hypomyelination, on T1, it will not be so much hypo. Maximum it will be hyso. And sometimes it will be more like, you can see here, it's a case of 11-year-old with PMD. The white matter is not at all hypo. It's almost hyper to gray matter. And here on T2 weighted images, it's not so hyper. So this is how an hypomyelination looks at. And you also look at the volume. The volume of the white matter is less, which typically happens in hypomyelinating disorder. So after ruling out, especially in cases of mild signal abnormality, if you have to, when you're ruling out the hypomyelination, you have to come to the white matter pathology, which is a dysmyelination or a demyelination. So dysmyelination is classical or leukodystrophies. Then you have to, depending on the things, there is a pattern of abnormality. What you're looking at, the distribution, like specific lobes and posterior fossa, we can select the selective differential diagnosis. Of course, we also look at a special MRI characteristics. What are these? In some of the cases, what we see is the cystic white matter degeneration, anterior temporal lobe cyst, then megalencephaly, enlarged perivascular spaces, additional involvement of gray matter structures, especially the basal ganglia and thalami, associated cortical dysplasia. Then we also look for a contrast enhancement, calcium deposits, microbleeds, any spinal cord involvement, of course, and evolution of pathological changes over time. So there are special MRI characteristics in addition to white matter changes you look at to arrive at a specific diagnosis. So coming to this case, the case which I was showing. So yeah, so this is a classical case of X-linked adrenoleukodystrophy. So here you can see these are some kind of a dystrophic calcification because of a long course of a disease, prolonged duration of a disease. Usually the affected white matter will undergo dystrophic calcification. So classically there is involvement of splenium of corpus callosum. Here we can see what you see along like this brainstem is basically involvement of a corticospinal tract. This is classically involved in adrenoleukodystrophy. That's why patients will have a motor symptoms. This is on a diffusion weighted images. So we'll see bright the leading edge, the inflammatory zone, so shows diffusion restriction. This on ADC. This is on contrast enhanced images. So you can see enhancement of the inflammatory zone. And of course, in the spectrum, we'll see like whenever there is a involvement of a myelin, more myelin turnover, it will lead to elevation of the choline. So this is classical X-linked adrenoleukodystrophy. So predominantly involving parieto-occipital. So it's basically a parieto-occipital predominance. So additional features, what we are looking at here, you can see the contrast enhancement. So that is there. It's very limited leukodystrophies which shows contrast enhancement. Can you give another example which shows enhancement?
No, sir.
Krabbe can show. Okay. So other like the predominant periventricular leukodystrophy with posterior predominance. Can you name one?
Typical Alexander.
The posterior predominance. Alexander will have an anterior predominance. Krabbe's itself. It's also called globoid cell leukodystrophy. So you can see classical involvement along the corticospinal tract. So I think that's the final. So can
actually,
one
of the attendees want to see the Canavan slide once again.
Yeah, come. I'll show. If any questions are there, let me know.
No. Questions are not there.
Yeah. Is it audible now? Sorry.
Yeah.
Is it seen completely?
Yes. Yeah.
Sorry. Yeah, you can see here the classical involvement of globus pallidus and thalamus. The sparing of putamen and caudate. This is very classical for Canavans. Should always remember. So it will relatively spare the putamen and caudate. That is not in our case, which I've shown. And always Canavan's disease patients will have more symptomatic. Will have megalencephaly, other like intellectual, motor, visual symptoms. So like the disease with juvenile presentation with mild symptoms are very rare. And basically, this is usually seen in Jewish patients. Usually, we don't see in our patients.
And one another question: what is other leukodystrophy with contrast enhancement? I think
Krabbe's will show. Krabbe's will have an involvement of optic pathway also. Optic nerves.
Do you do spectroscopy for all patients suspecting leukodystrophy?
Yeah, basically, like, see, role of spectroscopy in like it's proven in Canavan's disease. It will be Na is elevated because it's a disorder with where the Na will accumulate. So it will be like all other metabolites will be reduced. So we'll do it in almost all the cases. May not be like very, especially like when you come to the mitochondrial disease, it might help. So predominant leukodystrophy is not much of a help. So especially Canavan's, where we see elevated Na peak.
If you're suspecting a development delay in a child, and if you don't see any structural anomalies, do you do spectroscopy?
Developmental abnormality?
Developmental
of-
delay in a child. When it is sustained, not leukodystrophy. But
Yeah.
Suspecting a leukodystrophy or a dysmyelination or something, but we take the MRI looks normal. In those cases, will you do a spectroscopy or is it?
No, we
have
don't
any,
usually. No, we
Oh.
don't usually go to blindly doing unless it's some kind of a mitochondrial disease we are suspecting. So basically, if you don't see any pathology and white matter, we don't do,
Okay.
especially with some kind of a developmental delay with no other abnormality.
Okay. Yeah, and one more question. So kindly explain difference in dysmyelination and demyelination, or is there a difference?
Yeah, dysmyelination is basically problem with myelin formation. So it's inadequate myelin problem with the myelin formation. Demyelination is myelin formation is completely normal. So it will be the formed myelin is going for a death. So it's basically what we classically seen in MS, multiple sclerosis, edema. That's basically a demyelination disorder. See what here is, so formation of myelin will be affected. So there will be normal myelin will not be formed in these disorders. These are all dysmyelinating disorders, what we call the leukodystrophies. These are all dysmyelinating disorders.
He's asking if there is any imaging difference.
Imaging difference of demyelination and dysmyelination. Basically, dysmyelination category is, when come to imaging, dysmyelination is nothing but leukodystrophies. The thing is that most of them are symmetric. What we see, so dysmyelination, leukodystrophies are always symmetric. Look at these are all what you see are demyelination or acquired pathologies. So on imaging, they will not be, they will usually what we see is a multifocal areas of abnormality. So that is the main imaging pattern, and the clinical symptoms also definitely will be different. So like when you see a imaging appearance of an MS, multiple sclerosis, it's definitely different from a leukodystrophy, which will predominantly have, the thing is that they will classically bilaterally symmetrical abnormalities because it's a diffuse pathology involving a white matter. So of course they tend to have this kind of an appearance. Whereas this kind of demyelinating disorders is basically a disease of death of an already formed myelin. So we'll have abnormalities or asymmetric. You won't get this, and the clinical features are definitely different. So can I move to second case?
Actually, two more questions.
Yeah.
Can you explain the MRI features of hypomyelination once again?
Yeah. So you can see here. So basically, it's a 7-year-old kid. So in a 7-year-old kid, okay, we don't see this kind of an hyperintensity in the white matter. So when we look at this, so basically this white matter is also less. This is, you can see this white matter is amount is good. What the amount of white matter, the volume. So here the volume is less itself. It itself indicates that white matter volume is less. So in that case, when we look here, so on T1 it's relatively bit hypo to iso. What we say? So hypomyelination versus dysmyelination, like white matter pathology, dysmyelination or demyelination. So to look at them, basically look at a T1 weighted image actually. So hypomyelination will not be as hypo as I shown in this case. This is a classical leukodystrophy, like white matter pathology. Whether it's a leukodystrophy or a demyelination, both will have hypo signal on T1. So whereas the hypomyelination category will not will not be that much hypo on T1. Here we can see the 3 cases. This is not so much hypo. This is what major imaging finding the hypomyelination, and of course white matter volume will be less in hypomyelination. So because there will be a less formation of a myelin on the white matter volume will be less. Whereas here the white matter early in the course of disease, the white matter volume will be good. Here you can see the white matter volume is good. It's in a very early course of the disease. Whereas here it's an early course of the disease, but you see white matter volume is less. So it indicates that there is a problem in formation of myelin, like delayed hypomyelination. So the classical example is Pelagius March-Becker disease or hypomyelination. And of course, the 18q syndrome. You might have heard.
Okay. Is perirolandic white matter sparing a characteristic finding of L2 glutaric aciduria?
Yeah, they have described it, they spared. It's not in 100%. So I just have to recheck it. See, some of the cases they have described. So it's also here, like you can see, I don't think it's given in this. Some of the cases of L2 hydroxy, they have described this sparing, particular sparing of the perirolandic white matter. You can see. So maybe like I could not search this actually.
This is actually a proven case, right?
Yeah, yes.
Okay. So I think that's all from the attendees. So that was an excellent case discussion. Actually, this is one area where like all the residents find it very difficult. So this approach to white matter disease, but you have made it very easy and your approach was very good. So it was like excellent. So thank
Basically,
you, Dr.
just
Puneet.
wanted to
Yeah.
Basically, like wanted to like see when you are looking at a pathology, if it is symmetric, you have to know like it's basically looking at a leukodystrophy. Then it's a very exhaustive list of a differential diagnosis. In exams, usually they will get a classic cases only. So just you have to group it. That's it. What is the predominance? Yes, I've shown you the two, three cases now. Like if it is subcortical predominance in narrow differential diagnosis, it's a periventricular predominance. Narrow, like they have separate like set of diseases, especially. So like it'll come to 2 to 3 differential diagnosis. Like it's not always possible to come to final conclusion in all the cases. When it comes to exams, it's always a classical cases. So it will not be given very difficult. Like, they won't give you this case like that. I don't think so. So too difficult to judge that. So and even for like MD residents or like for cases like this, it's out of the box, it will be difficult because so people may not have heard of this name. Canavans, okay. So quite classical case. So you may not get this case on exam. Just for the approach of the cases, basically how to like show like which is the predominant abnormality, then go for a specific pattern of differential diagnosis which suits that abnormality. So I've shown the 2 to 3 cases. That's one with subcortical and one more with the periventricular with posterior predominance. That was the X-linked adrenoleukodystrophy. I think nobody will miss that kind of cases in exams. So it will be easy.
Yeah. Actually, there are 3 more questions. I'm sorry. when will you say NA is high?
So basically, see, the problem is that whenever we are looking at a spectroscopy, we always need to take a control. It's not only see, I'm looking at my pointer is audible.
Yes. Yeah.
See, when we want to compare the spectroscopic finding in this area, we need to have a control, and unless it's very difficult. See, when I look at the scale here, it's the problem like always when interpreting the spectroscopy, you should have a control. See, we have a scale here. You can see here, you have a scale. So see, we have my NA peak is around somewhere around 3,800. You want to know where this NA peak is in the normal white matter. So when we say elevated NA, we have to always look in the normal matter. What is the scale here? If it is at the 3,400 only, it's a normal. So that is what. Unless we have a control, don't compare here only with this height and choline creatinine. So always look at a normal white matter. You should have a control. Whatever the spectroscopy you're interpreting. So look at the normal, then only you comment. On the normal only, don't only look at this graph like this. You look at the scale, where it stays. Then compared to this, when you look at the pathology and look at the scale where it stays, it's at 3,400 because it is it's like this. If I match this, if you expand the scale to 10,000, it looks small. No. So opposite side, the scale is like somewhere for 3,200. The NA peak is low. The graph looks similar. That is what I'm telling. So when you're interpreting, always look at this scale. That is what I say. So whatever the pathology is, so you should always have a control. So that is why. So now for this case, I don't know whether it's elevated or not. frankly speaking.
In Canavans also, like there is not cutoff, right? So we'll just
Yeah, there is no
compare with
cutoff
the
actually. What they say is that like other peaks are reduced, it's predominantly we'll see high NA peak. So that is what.
Okay. And what's the pattern in Alexander? That's the next question.
So Alexander, it's a frontal predominance, what we see. Okay. So like it can, like it comes from subcortical to deep only. So in later course of the disease, so I don't have slides actually. Actually, I have one more PPT. I have to go and show. So it's basically frontal predominance. So it can show enhancement. I think I forgotten actually. So I didn't review it. It's a long back.
I think it's okay.
Yeah. So any other? So that's
Nothing,
like one thing is that one thing I want to stress is spectroscopy. When you are viewing at a spectroscopy, always take a control from the normal white matter and look at the scale. If you say it's elevated or not, look at the scale and compare. That's what I want to say.
Okay. Yeah.
That we usually miss. We look at only one thing at the pathology, say it's elevated, it's reduced. So also look at the colon scale where it's in the normal white matter, how much, at what level it is. So that's more reliable than only looking at a pathological spectroscopy on the pathological side.
Okay. Yeah, thank you, Puneet. We can go to the next case.
Yeah.
And next resident also, Dr. Arya.
Yeah, I'll show the next one.
Dr. Arya, you're ready, right?
Yeah.
Yeah, my screen is visible. Second case.
No, it's still the.
Oh.
Or is it my problem?
1 minute. I'll come back. It's coming now?
Yeah.
Yes.
Yeah, Dr. Arya. I'm audible. She's a 27-old female. Has a history of seizures since 8 years. So she developed recent onset of left upper and lower limb weakness, which recovered well. Okay, so this is a short history. So 8 years is a long history. Basically, a seizure disorder. Neurological wise, she's fine. Okay, so these are the images. Yeah, can you briefly describe this T1, T2 weighted images? What you're looking at?
Okay. We are seeing a relatively well-defined orthosegment density area lesion, which is noted in the right sagittal lobe involving the subcortical and periventricular white matter, which appears heterogeneously hypointense in both T1 and T2, with a well-defined hypointense area in T1, which appears hyperintense in T2. And in flare images, this well-defined T1 hypointense and T2 hyperintense area is showing suppression, suggestive of a cystic area. And the rest of the areas are not showing any significant suppression in flare. Then the surrounding white matter shows T2 and T2 flare hyperintensity, suggestive of perilesional edema. Then GRE sequences shows blooming. It represents the presence of either calcification or blood products within the lesion. However, the susceptibility weighted faint images shows both black and white areas within. So there is presence of both calcification and blood products within the lesion.
These are diffusion weighted images.
Then there is no significant areas of diffusion restriction within the lesion.
Post contrast.
Then post contrast images shows heterogeneous post contrast enhancement of the solid area, and there is no contrast enhancement of the cystic area. And then
this is perfusion. This is the RCBV, like relative cerebral blood volume, and this is the perfusion graph. Can you interpret? Can you say something?
The time versus signal intensity curve shows a fall with more than 50% recovery. And in perfusion images, there is no significant increased perfusion within the
it's mild. It was there. It was very mild. I have not given you the values. It's very mild actually, not too much. Should be fine. So these are MRS. This is from the center lesion of the central lesion. and it's the surrounding white matter.
Okay. So MR spectroscopy within the area of the lesion shows decreased NAA peak with choline elevation. Then choline is to NAA ratio is more than 2, suggestive of a neoplastic lesion. Whereas choline is to creatinine ratio is less than 3, suggestive of a low-grade neoplasm.
Okay, basically it's a lot of noise is there because when you say, when you look at a spectroscopy, you have to look at the morphology of the lesion. When you have a lot of calcification and hemorrhage, so the spectroscopy becomes more of unreliable, will fill a lot of noise. This is what happens here. So this is relatively the surrounding area. You can see relatively good water supply. Okay, so yeah, you're right. The choline is elevated. So because it's elevated, like other parameters are not like in the low range, so they're with mixed with the water signal. It's the periventricular area, so the edema. It's okay. I'll come to it. Then, what do you think? What do you think about this lesion? The long-standing history, 8 years. She's symptomatic for many long years. So she has a lesion in the right parietal lobe, which is located in the subcortical bar deep white matter. So you missed one thing. Is there anything here? What is this? This one?
That's a cystic area.
So this is a very important aspect when you come to the diagnosis in this case. We have a cystic area. Is it intraparenchymal or extraparenchymal?
It is intraparenchymal.
So the lesion looks, see, when you look at the lesion, it's some kind of a multilobulated kind of a thing. We have 2, 1, 2. In coronal, it looks like a 3. So when you look here, you can see it has a different signal intensity components. So you have a periphery, the center. Periphery have multiple like T2 hypo hyper. The central part of the lesion is hyper, especially on this, take this. So here you can see the central part is hypo here and hyper. So, and we have one predominant perilesional cyst, the associated cyst, definitely. So, because it has a lot of implication. So, when it comes to, does it have any mass effect?
No significant mass effect is seen.
So, when we describe a mass effect, it has a 2 like components: regional mass effect and composite mass effect, like complete. Does it have a regional mass effect?
Adjacent sulfur and gyre are seen.
Yes, it has a regional mass effect, not like major mass effect. Regional in the form of phase sulcal spaces. So and another thing is it crossing the corpus callosum?
No.
So because it has important differential implications. So here we like heterogeneously solid cystic lesion basically. Okay. So basically lesion is not cystic, it has associated cystic component. Okay. So it's not crossing the corpus callosum. So edema, do you think is appropriate to the lesion or very disproportionate to the lesion?
Appropriate to the lesion.
Yeah, it looks appropriate to this kind of a lesion. It's not very disproportionate. Why I'm asking this?
High grade lesions.
Yeah, especially which lesions which show disproportionate edema? Yeah, it's metastasis. When you see a metastasis, see the location is subcortical and deep. Okay, so it's classically seen in this kind of locations. So and edema will be very disproportionate. If you have a metastasis like this, and edema will be more, it will have a more mass effect. You would have find a midline shift here, definitely. So this edema is not too much disproportionate. So it's just enough. So now we'll come to like a flare. You can see the cystic component, it is suppressed on flare. It's almost like a CSF signal. So now we have this. What is the sequences? This and this.
GRE and susceptibility weighted image.
Yeah. So like how you differentiate them? Calcification and hemorrhage in phase and magnitude image.
In face images, we have to compare it with any normal structure like covert plexus calcification or pineal gland calcification. Whenever we are seeing signal intensity similar to those calcifications, we can say it is the presence of calcification within the lesion, or we can either compare with vein vessel adjacent to the lesion. And if the signal intensity in that vessel and within the lesion is similar, then it may be due to blood products.
Yeah, so that is the best way actually, because we depends on the scanner also. It's a right-handed system, left-handed system. You have to like memorize all those things. The best way is just to look at adjacent vascular structures, especially it's a dense calcification or dense space. Sometimes it will be very difficult. In this case, you had a CT, I could not give you. So it's predominantly calcification. Maybe, of course, there are area of microhemorrhages might be there.
Okay.
So no diffusion, not much, because see, when we see a lot of these calcification structures, diffusion becomes very unreliable. So basically, in diffusion, we are looking at a cellular lesions actually. When you have a lot of calcification, it becomes very unreliable. So it's not much of help for characterization of these lesions in this case. So contrast enhancement. So the lesion is showing good, like these areas are showing very well, robust enhancement. So we don't see any involvement of adjacent meningeal enhancement, leptomeningeal enhancement. That is a very important thing. And I don't see any any periependymal spread also. It's not crossing the corpus callosum. So on perfusion, so what is the significance of this signal intensity curve?
Signal intensity curve, if it is showing more than 50% recovery, it usually represents a high-grade lesion. And if it is less than 50%, it will be a low-grade lesion. And if it is crossing the baseline, usually it can be a lymphoma.
Yeah, so basically, so when you're looking at this kind of, so when you're doing it, it's basically a T2 star perfusion, DSC perfusion, dynamic susceptibility perfusion. What it assumes while doing a perfusion is that we have some set of principles while designing this perfusion sequences. So it assumes that contrast stays in the intravascular space only. So this is what the time when you get contrast. So when it enters the tumor vasculature, what happens is that signal intensity of the lesion decreases. This is a sharp fall. So when the contrast goes out of the tumor vasculature, so it signals recover. This is the normal thing. So what happens, what you say is, what happens in metastasis? This is in case of like primary tumors, especially the low grade, high grade. It's usually the signal intensity. Can you give me 1 minute? Okay, only 1 minute. Sorry for the disturbance. Hospital call. Yeah, I'm audible now.
Yes.
Huh? Hello.
Hello.
Yes,
am I audible?
Yeah. You can continue.
Yeah, I'm describing this percentage signal intensity like recovery. So in a metastasis, usually it don't come up because of loss of blood-brain barrier permeability. So in lymphoma, you said it's overshoot. So whenever you're looking at a like perfusion images, make sure that you also look at these graphs. It will also help to arrive at differential diagnosis. Okay. So on spectroscopy, yeah, you told, right, because there is a lot of noise, like it becomes very unreliable when we have calcifications, hemorrhage in the lesion. Spectroscopy becomes very unreliable, especially the peaks, which like very small peaks will be mixed with this water. So we have advanced techniques to suppress this, but too difficult to, and even the perfusion, T2 star perfusion becomes unreliable, especially when you have a lot of calcification, hemorrhage in the lesion. We go ahead with T1 perfusion actually. So we in our practice, we do both T1 and T2 when we have lesion with this kind, because basically this DSC perfusion is a T2 star weighted. So signal intensity will always lose because we have a lot of calcification. So it will interfere with the perfusion signal. So can you summarize this case?
Okay. So a 27-year-old female who had history of repeated episodes of seizure since 8 years, now presented with complaints of left upper limb and lower limb weakness following a cluster of focal seizures, and contrast enhanced MRI of brain shows a well-defined solid cystic lesion involving the subcortical and periventricular white matter of right parietal lobe. With solid components showing heterogeneous post-contrast enhancement with areas of calcification and a few areas of hemorrhage within. And in perfusion images, there are few areas of increased perfusion.
Yes.
With the MR spectroscopy showing raised choline peak with decreased Na peak.
Yes.
With choline is to Na ratio of more than 2 and choline is to creatinine ratio of less than 3, suggestive of a low-grade neoplastic lesion.
So what kind of a neoplasm you are looking at?
It is an epileptogenic tumor which has got both a solid and cystic components within and contains areas of calcification and hemorrhage within. And it is a low-grade lesion. So the possibilities may include.
Why you say low grade? Why you say low grade?
It is a long-standing history. First, it is a long-standing history. Then there is no areas of diffusion restriction. Then perfusion is not much increased with choline creatinine ratio of less than 3 in MRS.
So what kind of a low grade lesion you are looking at? So what are your DVs? I just wanted to know 1, 2, 3 possible. Can you give?
Okay.
What's in your mind?
The DVs which I'd like to consider include a papillary glioneuronal tumor, then can be a pleomorphic astrocytoma without adjacent dural involvement. Then
So and the age of the patient is 27.
Papillary glioneuronal tumor usually occurs in young adults in second decade.
Okay. What are the imaging characteristics of papillary glioneural tumor?
It will be a well circumscribed cyst with enhancing solid areas within with no diffusion restriction, and there will be low RCDV, and there will be presence of superficial fibrosis, then hemosiderin and calcifications within the lesion. And perilesional edema is rare but can occur in cases.
Okay. What's your second DD?
Second DD is pleomorphic astrocytoma without adjacent dural involvement.
Is it seen in this age? It's a location classical for it?
Actually, pleomorphic astrocytomas usually are cortical-based lesions, but here it is subcortical and periventricular.
Yeah. Yeah, papillary glioneural tumor can be considered looking at the morphology. So you're right. So it doesn't fit with the yes. Any other thing fits in mind? Okay, we'll
Then
come
imaging
to the diagnosis. Yeah.
No,
No, I didn't get.
no.
Okay, so like when you describe the imaging, like yes, you have to analyze T1 and T2 characteristics of a lesion. So basically, you have to see whether it's where it's exactly sitting. It's a cortex, subcortical white matter, or it's like that will make a difference because there are few tumors which are cortical based. So can you give some examples of cortical based tumors?
Pleomorphic astrocytoma.
Okay.
Then
so that is not the first answer should give. Cortical based tumors, ganglioma, DNET, desembryoplastic neuroepithelial tumor. There are two classical. Then one more aggressive tumor will be not aggressive. So one thing which arises from the cortex, oligodendroglioma, which also arises from the cortex. So when you're looking at the lesion, you see where it is, Anta. It's in the cortex, subcortical white matter thing. So the first important thing is interaxial or extraxial. That's out. It's an interaxial lesion. Okay. So now, is it cortical based? No. Okay. It's in the white matter. So basically, lesion is situated in the white matter because see what lies in the white matter basically. Glial cells, astrocytes. So astrocytomas. Okay. So oligodendrogliomas. These are the locations for white matter lesions. So thinking of a primarily bright white matter. So now the location. After this, we'll analyze like morphology of the lesion. So what all we look at it is calcification, hemorrhage, if anything is there, diffusion, restriction. These are the some of the characteristics we look at on basic sequences. Then of course we look at edema, how much it is. Then mass effect, then one important thing, when we have do we have any associated other lesions somewhere? So it's not there. Then if it is crossing the corpus callosum, it will also make a difference. What are the lesions which cause corpus callosum? Can you give us some examples?
Glioblastoma.
Yes. Very important. One more, lymphoma. Lymphoma can cause corpus callosum. And one more entity. Have you heard of gliomatosis cerebri? Yeah, that will also cause corpus callosum. One more non-tumorous lesion which can cause corpus callosum, radiation necrosis. It can cause also corpus callosum. Of course, there are basically I'm talking about tumors. So is it causing corpus callosum?
No.
No, it is not causing corpus callosum. So it's basically it's in the white matter lesion. So okay, so it has a solid and cystic components. Very important. Okay, so edema is appropriate to the lesion. So other characteristics, it has chunk calcifications as well as maybe lesions of microhemorrhage. So good enhancement, elevated perfusion, maybe mild. So this can it be metastasis?
No.
Do you consider?
No.
So why?
Time versus intensity curve showed recovery.
See, when you look at actually when you're interpreting the images, so don't isolatedly interpret, don't only take spectroscopy, don't only take perfusion. You also take into consideration the morphology of the lesion, which I told. It's a lot of calcifications, hemorrhage. So this your spectroscopy and perfusion can become unreliable. So you always stick to this basic sequences, interpret the advanced imaging features based on this only, always. Okay, so your basic tumor characteristics, the differential diagnosis should always be made on this basic image, basic sequences. So advanced refinement, grading and all is for like whatever your spectroscopy, what we say in like our language is a multi-parametric imaging. So basically the diffusion, perfusion, spectroscopy are part of multi-parametric imaging. So basically to guide, refine, like it's a grading of the tumor for this. So to characterize a tumor, you always like basically rely on this actually. Okay, so this age, location, tumor characteristics. So I'll come to the discussion parts. I have not given you the diagnosis. I'll give you what it is, Anta. Of course, papillary glioneural tumor is a very well differential diagnosis. I don't have other things to think of because I'll show like the cases. It'll sum up. 1 minute, I think. Yeah, my screen is like visible now.
Yes.
Yes. Okay. So when we look at a tumor, especially now, like I stick to interaxial tumors, supratentorial. Okay. So I'll show some of the cases. Like, see, when very important is age of the patient. There are certain tumors specifically seen in the age group So we don't see some tumors in the later. We don't see pilocytic astrocytomas in a 40-year-old. So it's a basically tumor of young. Okay. So usually we don't see most of the cases a GBM, glioblastoma, in a 2-year or 3-year-old. So basically very important age. It's a core component when analyzing it, giving and formulating a differential diagnosis. Very, very important. So localization, intraaxial, extraaxial, especially for a like small to moderate lesion, it's not too difficult to differentiate. So I'll show like some of the features to differentiate intra and extra. Then always effect on the surrounding structures. You have to look for mass effect. Then because especially edema, and then it's the extra-axial lesion, we'll have a bone erosion and all. And whether its lesion is multiple or solitary, that will also have important implications. Of course, on imaging, you always look for specific characteristics in the lesion like calcification, fat, cystic component, and T1, T2, DW, diffusion characteristic of lesion. Then, of course, contrast enhancement. So, in this case, it's a 27-year-old. So, intraaxial lesion, heterogeneously enhancing, perilesional edema appropriate. So, lesion is centered in the white matter. So, there are calcifications and associated cystic components also. So, like an advanced imaging, perfusion is increased, choline peak on MRS. So, it increased that it's basically some kind of a maybe. So now the thing is a lot of change in the tumor nomenclature and all. In the latest we have 2021 WHO classification of brain tumors, the 5th edition. So there is it's entirely shifted into molecular features. We don't relay the grade of the tumor and based on anything like what you said. We use perfusion is elevated, it's high grade tumor. That all it's gone now. Even on the histopathology, if they say grade 4 tumor, grade 1 tumor, so everything like is second. So second to the molecular imaging features. They do gene analysis. The important thing is IDH mutation. What we see, how people go and read about latest WHO classification, that is 5th edition now. So recently come up in 2021. So WHO classification of brain tumors. Now see, till 2016. So what's more relied on histopathology, it is high grade, low grade and all. So now these molecular genetics takes precedence. So even on histopathology, if it's a grade 4 tumor, on molecular genetics, if it has some gene like specific genetic mutation, it can be called as a low grade tumor only. So that is the thing. So in this case, so perfusion, choline, everything is okay. Like can be these things cannot say when we have a genetics, so they don't come up first. The lesion is not midline crossing. There is no CSF spread. So this is a rough classification of supratentorial brain tumors. So especially when it comes to intraaxial tumors, what we have? Glial tumors, non-glial tumors. What are the glial tumors? They're basically glial components. If a tumor is astrocytic origin, or that is called astrocytomas, oligodendroglial origins, oligodendrogliomas, then ependymal lining cells, this is ependymomas. So non-glial tumors, these are cortical based, which arise from the cortex. They told ganglioglioma. So these are all other tumors like central neurocytoma. DNET is also cortically based tumors. These are all tumors which arise from neuroglial tumors, neuronal as well as glial components. So I show some of these too. These gliomas. So I've told you the age specifically. You can see here less than 10 years. We see these are the tumors which are more commonly seen, like choroid plexus tumors, teratoma, germinoma, craniopharyngioma. Of course, when it comes to when it comes to glial and non-glial tumors, it's medulloblastoma and ependymoma. What we see in it's a rough guide. So I've not included everything. It's not included here. So medulloblastoma and ependymoma. So we can see here astrocytomas can be seen in all the age groups. It depends on it. Low grade tumors are specifically seen in this less than 10 years, which I'll show. So this high grade tumors like grade 2 astrocytoma, what we call diffuse astrocytoma, anaplastic astrocytoma, and the higher grade, the glioblastoma, will be seen in later ages like 30 to 40, 40 to 50, more than 60. So this is a rough age distribution. So here you can see in the glial tumors, this is basically astro and oligoglioma, and non-glial tumors, which I've shown also. So how to differentiate an intraaxial and extraaxial tumor? Here you can see predominantly an extraaxial lesion. So see, what are the features which suggest is nothing but on contrast enhanced images, you can see associated dural thickening and enhancement. On plain images, we can see if the lesion is small, you see a CSF cleft between the lesion and the tumor. So what are the features which are definitive for an extraaxial lesion is a CSF cleft. Also, when we see some vessels between the lesion and adjacent gray matter, that is what we call a vascular cleft. So that is also definitive for extraaxial lesion. Then we see a buckling of gray-white matter junction. Here you can see in this area the buckling of gray-white matter junction. So of course the lesion is so superficial. Here you can see here it is causing mass effect on the adjacent bone. So it is causing bowing of the bone. This is also feature of extraaxial lesion. So when we see an intraaxial lesion, it looks like this. It will not be contiguous with any dura or a bone. Usually, so that we don't get any bony changes. So usually we'll get effacement of a CSF space here because of regional mass effect. We don't see any buckling of gray-white matter. So destruction of gray-white matter junction will be seen. This is a classical intraaxial mass. This is a classical extraaxial mass, which is a meningioma. So now these are some of the supratentorial tumors. So astrocytic tumors. In this, low-grade astrocytomas, then anaplastic astrocytomas and GBM, and these are other tumors which will show how they appear. This is grade 1. So grade is based on the histopathology. So they look at mitotic features, proliferation index, nuclear atypia, vascular like microvascularity. These are some of the histopathological features. We'll look at it. If they're all on the higher side, they'll grade it to higher grade tumor. Grade 1 tumors will not have all those things. They don't have any kind of too much nuclear atypia. They don't have any high proliferation index. They don't have microvasculature. They don't have microhemorrhage. These are all grade 1 tumors. So most common is pilocytic astrocytoma, classically called juvenile pilocytic astrocytoma, usually seen in children. The classic location is cerebellum, infratentorial. They can be seen in supratentorial also. The classical location is, so the most common appearance is cystic nodule. Cystic vision is solid enhancing nodule. So usually what we see, low-grade tumors, they don't enhance. This is one of the low-grade tumors which brightly enhance. You should remember. When you look at an astrocytoma, grade 2 astrocytoma will not enhance. So it is not like that. It's a grade 1 astrocytoma, but still it enhances. So enhancement is not indicator of grading of the tumor. So which are the other tumors which can enhance with low grade? No, Anju, right? Arya. Which are the other low-grade tumors which can enhance? One is pilocytic astrocytoma.
Then this pleomorphic papillary glioneuronal tumor will enhance, solid component will enhance.
Yeah.
Then ganglioglioma.
Yeah, ganglioglioma. This is one of the low-grade tumor which can enhance. So then
Gangliocytoma.
Yeah. These are some of the low-grade tumors. You can still grade 1 tumor. So what we see is that low-grade tumor don't enhance. So this is not the case. Okay. Then even grade 1 tumor, subependymal giant cell astrocytoma, SEGA. So that's also a low-grade tumor which enhances. So classically solid with cystic nodule, like pure solid tumors are also there. So what we see here, what specific thing is that we don't see any edema around this. This is classical for this kind of grade 1 pilocytic astrocytoma. We don't see any perilesional edema. This is how a classical grade 1 pilocytic astrocytoma looks. Even also grade 1, the case reports have been there. They can spread through CSF. So even the grade 1 tumors can also spread. So now what you are currently saying, your more interesting PXA, pleomorphic xanthoastrocytoma, it's also a low-grade tumor. So usually they have they have adjacent meningeal involvement and enhancement. This is how they look on a CT. the solid cystic lesion, the enhancement, this solid portion will be along the meningeal side. This is a PXA. This is also a low-grade tumor which enhances. So now the third low-grade tumor which enhances Sega. So it's usually seen in setting of tuberous sclerosis, located near the foramen of Mamru. It's also a grade 1 tumor. Grade 1 tumor. So is it intraventricular tumor, intraaxial or extraaxial? Arya? So it's basically when intraaxial tumor, intraventricular tumor is extraaxial only. We consider it as an extraaxial lesion only. So what do you see in this location? Any other DD you can think of?
Foramen of Monro colloid cyst.
Yeah. So it will be bright. Okay. So another thing is colloid cyst. So this one. So it's okay. So we have seen the 3 low-grade tumors. Appearances like this. So now we'll come to. So this is another Sega and MRI. You can see classical location. So now come to the astrocytic tumors, grade 2 tumors. So this is classical astrocytoma. So how it looks is like bright on T2. You can see edema is very minimal. It's not there also. They usually a very minimal edema they have. They don't enhance actually. You can see they don't enhancement. This is a flare. What we see is that so on flare it will show suppression. You can see the T2 signal is suppressed. This is the classic appearance of grade 2 astrocytoma. The classic textbook picture. So as I've already told, grade is different based on the histopathology. So like gradation, like mitotic index, they look at a proliferation index, they will be more. So like based on that, they'll on imaging, is it possible to differentiate a grade 2, grade 3 and grade 4? Arya?
Imaging, according to the new classification, it is molecular.
Yeah, now like whatever we say everything molecular immunogenetics takes the precedence. Still, like it's like we still like say when you give a report, we'll give low grade, grade 2 astrocytoma. If you report this, we'll give grade 2 astrocytoma. You have heard of IDH mutation, isocitrate dehydrogenase. Have you read about it?
Yeah, I have heard about it.
Yeah, it's okay. So you people should read about latest WHO classification. So that's in 2021 fifth edition. So basically this is a classical low-grade astrocytoma. We'll see a relatively well circumscribed lesion. It shows suppression on this plane. It usually shows no enhancement. So that doesn't mean like always it's a low-grade. Most of the like cases of low-grade like grade 2 astrocytoma, they don't show enhancement, and perilesional edema will be very limited. So this is classical grade 2 astrocytoma. So it arises from the astrocyte cells, this in the white matter. So now grade 3. So when we compare grade 2 and grade 3, the perilesional edema will be more. It will show some enhancement. All the components of the lesion will not show enhancement. Some portion of the lesion will show enhancement. So again, so on histopathology, the features will be more like whatever the feature will see, it will be in the higher grade. It will not be up to grade 4. So it is a grade 3 tumor. Ultimately, if you leave this lesion, it will progress to grade 4. Even the grade 2 also will progress to grade 4 with time. So, but grade 3 progress very earlier. So when a lesion like this, so grade 2 progress to grade increases to grade 3 or grade 4, what we call it's an angiogenic switch from low grade to high grade. Can we predict? Yes. With a perfusion imaging, we can predict. If you do a perfusion imaging on this, even though it will not show enhancement, perfusion parameters are high, so we can detect this lesion is going to progress into high grade within an early period of time. So this is called angiogenic switch. Read about it, angiogenic switch. So the advanced multiparametric imaging can predict the tumor progression, whether it is going to progress. So this is grade 3. So to differentiate on imaging, like so morphological features can help. So you can see in this, there is no too much of perilesional edema, not much of enhancement. Here you can see some perilesional edema, enhancement. And advanced imaging like perfusion. So perfusion parameters are elevated. When we look at gradient images like SW images, we'll have microhemorrhage and in the grade 4, that will be more in the higher grade lesion. Anaplastic astrocytoma will show less kind of a thing. So basically tumor, it's a tumor heterogeneity, more tumor necrosis, more microhemorrhages, it will be a grade 4 tumor. Less tumor necrosis, less enhancement, to be a grade 3 tumor. It's on imaging. So now look at the grade 4 tumor, GBM. So glioblastoma. You can see tumor, it's a solid cystic lesion. Cystic area means this cystic area is within the tumor. This is a necrosis within the tumor. It's definitely different from what we see in our case. It's tumor associated cyst. So definitely because this tumor has overgrown its blood supply, undergone necrosis. This is classical appearance of a GBM. So tumor with necrosis, tumor with microhemorrhage, tumor with perilesional edema. So you can see it's a solid rind, thick solid rind. You can see on the post contrast, you can see a thick irregular rim. This is a classic appearance of a glioblastoma multiforme. This is another case of GBM. Here you can see it's a very heterogeneous lesion. You can see on SW here, a lot of microhemorrhages. This is a classical appearance for a GBM. You can see here expanded lesion and look at this post contrast. Very heterogeneous area of peripheral enhancement and lot of central necrosis. So this is what we classically see in grade 4 tumors. This amount of necrosis, you don't get it in anaplastic tumors, like a grade 3 tumors. So this is perfusion. I don't have a color coded map. This elevated. This is white area. It's elevated perfusion. And you can see this is a T2 signal intensity curve. It has almost returned to baseline. And of course, choline. So what we see on MRS in high grade tumor, like the glioblastoma, is elevated choline. Along with this, what is this? What is this peak?
Lactate.
Yeah. Why it happens? It is a lot of necrosis in the tumors. We'll see. So lactate peak. So how to differentiate a lactate and lipid peak?
This peak occurs at 0.9 to 1.4 and lactate at 1.3.
So both will be like this only. So especially on 135, lactate will invert like this. Lipid will be up. So why I am showing this? This is one like for signal intensity curve, importance of signal intensity curve. Here we can see this is a case of metastasis actually. A 26-year-old with metastatic CA breast. You can see the T2 perfusion curve. It will not return. It will return to baseline very less. If immediately you can see stays below the baseline. This is normal baseline. Whereas you see a GBM, it has returned to baseline immediately. Here it takes very long time. Sometimes it will not return also. So this looking at the signal intensity curve will also help if in difficult cases. So of course you have to interpret all this in conjunction with routine sequences. What will T1, T2 contrast nest? Isolatedly don't interpret perfusion or MRS sequences because as I've already told, a lot of factors interfere with their interpretation, especially if a lesion has a lot of calcification membranes, it will not be very much reliable. So we have seen very low grade tumors like grade 1 pilocytic astrocytoma, then PXA, SEGA, subependymal genital astrocytoma, then grade 2 tumors, that is diffuse astrocytoma, grade 3, that is anaplastic astrocytoma, and grade 4, that is glioblastoma multiforme. Does any one of the lesion which I've showed so far fits in the lesion which is shown in the case discussion? Arya? No. No, Allah?
No.
Yeah, so it's not an astrocytoma. It's not a oligodendroglioma. Then it is not a, yeah, it's none of them so far now. Okay. So we'll see. So this is gliomatosis cerebri. So like a lot has been changed about this gliomatosis cerebri. Previously, it's like we don't know the cell of origin of this. So now latestly, what from 2016. So there are two classifications. The 4th edition of WHO classification came in 2016, and the 5th edition is 2021. From 4th edition itself, the 2016, they have given precedence to molecular markers. From that time, so gliomatosis cerebri, they consider just it's a pattern of glioma spread. So no more a separate tumor now. It's a pattern of spread only. If it involves more than 3 lobes, you can see here, it is spreading like, so you can see a mass effect of this lesion. This is how a gliomatosis cerebri pattern looks. So usually it spreads, it kind of a spreading abnormality, and we'll have a mass, like we have mass occupation like this. So suppose if it is some kind of a some encephalitis, it will have this kind of this other DD is closed DD for this encephalitis. So it will not have a mass occupation like this. Of course, you can see the involvement of white matter also. This all points to gliomatosis cerebri. So according to latest classification, it's just a pattern of tumor spread. It's not a separate tumor, they say. So now separate second set of tumors, oligodendroglial tumors. So usually the age is bit late. So they arise from the cortex, like they involve the cortex, rather say cortical involvement. So compared to other tumors which are described, they involve the cortex. The calcification will be predominant in future. The 70 to 90% they will show calcification. Hemorrhage will be little less. So how it appears on an MRI? This is like this. You can see here, and T1 it's hypo, T2 you can see here the cortical gray matter is expanded. This is insular perinsular cortex surrounding this. You can see compared to this, there is expansion of the cortical gray matter. This is very classical in case of oligodendroglioma. See, whereas what we saw in grade 2 osteocytoma, it's predominantly located on the white matter. Here cortical involvement will be there. This is how a classic oligodendroglioma look like. So we'll have involvement of a gray matter. You can see. And this is of course the CT showing chunk of calcification, which is usually seen in the oligodendroglioma. So coming to the enhancement, this is a post contrast. Oligodendroglioma, even the low grade, here also we have a grade 3 and grade 4, low grade and high grade. Low grade oligodendroglioma can enhance. Can see here some very mild enhancement. I'll show another case. You can see here the cortex is involved. We have a lesion with cortical involvement. This is a typical oligodendroglioma. It will not be purely a white matter based lesion. It will involve the cortex. It will have a calcification, most 70 to 90%. Enhancement pattern is variable. Some show enhancement, some doesn't show enhancement. Even the low grade oligodendrogliomas like grade 2, grade 3 can show enhancement. High grade may not show enhancement. Enhancement is not reliable in oligodendroglioma for grading. So of course, it will show choline peak. So reduced Na and creatinine peak. This is how oligodendroglioma look like. Does it look like the case which I shown? No. So it doesn't look like oligodendroglioma, and age doesn't also fit. Now, ependymomas. So what in what age group we see ependymomas, Arya?
In pediatric age group.
So basically there are two age groups, usually less than 5 years. Younger age, what is the location in younger child? Is less than 5 year old. What is the predominant location for oligodendroglioma?
Ependymoma.
Sorry, ependymoma.
Ependymoma usually within ventricles, predominantly in fourth ventricle.
Yeah, so predominantly these are like, see, so yeah, in a child less than 5 years, they usually intraventricular, so usually infratentorial. So classical ependymoma, what we see, fourth ventricular lesion extending through foramen of Megandi and foramen of Luschka. So this is with classical features of intratumoral hemorrhage, calcification, the classical infratentorial ependymoma. Of course, the ependymomas can arise in supratentorial lesions, supratentorial areas, usually in 30 age group, 30 to 40 in this age group. When they arise supratentorially, most of them are extraventricular. So what is the imaging features of this ependymoma, supratentorial? Usually, describe, tell me.
There will be a specific sign called periwinkle sign.
Yeah, a periwinkle sign.
Then calcification may be seen.
Yeah.
With cystic and solid areas.
Yes.
And the solid areas will show heterogeneous post-contrast enhancement.
Yes. Yes.
And a hemorrhage can also be seen in some cases.
Yes. 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 So this is one of the post contrast, or it's an NCCT. I feel okay, and forgot actually. This is how a supratentorial ependymoma looks. So it's very difficult to say it's intra or extravascular, extraventricular. I don't have other slides. You can see this is a solid component and a cystic component of the lesion. You can see a calcification. Of course, not much of a perilesional edema. They usually present because when you have this kind of a mass, so we usually will have edema. It's not shown here. So this is how a classical supratentorial ependymoma looks like. So like they have now they have a classification for a supratentorial ependymoma based on the genes involved. Okay, so you have to read about it. So does it fit somewhat or no?
Yes. Yes.
So it's possible because we have a age group also fits, the morphology somewhat fits. So I would have shown, I had a CT, I had shown this, if I had the CT, I would have shown. So it was like very classical imaging feature. So the CCT, it was almost fitting in the diagnosis. So the case which I described is a supratentorial ependymoma only. The histopathology came as ependymoma. So it was YAP positive. So that's the tumor molecular genetics. So you read about it. So I have not prepared a slide for it. So it's imaging appearance was quite classical. When you see this kind of a solid cystic lesion in when white matter with some amount of perilesional edema, which is shown. So you should think of differential diagnosis as ependymoma. That's what I say. So of course, you told papillary glioneural tumor will also look like this. Okay. So subependymoma, it's a one more type of ependymoma. It's a very low grade tumor. So usually seen in this kind of age group, but it's intraventricular. So usually it won't enhance. The classic location, they say it's a fourth ventricle only. This is how a subependymoma look like. It's an intraventricular tumor. So it usually show so enhancement is very limited. Like usually more than 60% don't enhance. So this is a classical appearance of a subependymoma. What other tumor look like this in this location? Arya?
Central neurocytoma.
Yeah, central neurocytoma. Usually they are very large lesion. They resemble the classic location is like this only. They will be very large. They also show focus of calcification and sometimes hemorrhage. So they usually show enhancement. So other lesion which look like this in this location is central neurocytoma. Now other category of tumors. So I've described basically now glial tumors. First I showed very low grade tumors, pilocytic astrocytoma, pleomorphic xanthoastrocytoma, and SEGA. Then astrocytic tumor, grade 2 astrocytoma, the grade 3 anaplastic astrocytoma, and the fourth grade is glioblastoma. Then oligodendroglioma, the other one is ependymal tumors, that is ependymoma, the classical supratentorial ependymoma and subependymoma. So now in the intraaxial category, supratentorial, I'll show some of the neuronal and mixed glioneural tumor. This is the classification. These are the set of tumors in this location: the gangliocytoma, ganglioglioma, anaplastic ganglioglioma. This is the desploplastic infantile glioma, DNAD, and central neurocytoma. I show this is the classical appearance of a ganglioma. Usually, temporal lobe is the common location. Cortical based tumors will have a multicystic appearance like this. They will show some of the tumors for enhancement. This is classical ganglioma. The patient will be having seizures in this, young child. So another is DNAD. You can see a low grade DNAD is basically a multicystic lesion, cortical based. You can see the scalloping of the overlying cortex. I'll show. You can see the classical appearance of the DNAD. So basically a multicystic lesion, cortical based, erosing all this lesion. We don't see any perilesional edema. This is the characteristics of cortical based neuroglial tumors. I think it's okay for now. I'll show some spotters, or if you have any doubts, can ask me. because there I have lot of slides to show, but in the,
I know, I think it's already 8:40.
yeah, that's why. If you're okay with that, I'll leave it. If you are interested, I can show some spotters.
Yeah, I think we can show some quick spotters. Gomati ma'am?
I think, how many spotters you have, Puneet?
I'll quickly run through it.
Okay.
So maybe I'll stop at 5 to 10 because in the interest
Yeah.
of time, I don't have.
Okay.
Right. I'll quickly show. Okay.
Yeah.
Arya, just I'll ask you questions, 1 or 2. Just I'll guide you also. Don't worry.
Okay.
Huh? Okay. Minute. Okay. Yeah. Now it's visible.
Yeah.
Arya. See, this is a case 145-year-old acute onset right hemiparesis, 2 hours duration. Can you describe this abnormality on CT? Right hemiparesis.
Right hemiparesis. Right hemiparesis.
Yeah.
The non-contrast CT sessions actually.
Sorry, it's a left hemiparesis. It's a mistake.
Okay. So non-contrast CT sessions of brain shows hypodensaria involving right insular cortex and external capsule with a loss of insular ribbon sign, and left lentiform nucleus is also involved with
Okay, done. So what is this? What is it? What is this?
Hyperacute infarct.
Hyperacute. So what is the scoring system used in this to evaluate the degree?
Aspect score.
Yeah. Can you expand aspects? Alberta.
I don't know.
Yeah, it's okay. Alberta stroke program, early ischemic stroke scale. Okay, so basically it's used to estimate the degree of involvement, basically, because we consider treatment for mechanical thrombectomy, we assess the damage. If the aspect score is less than 6, usually chances after doing mechanical thrombectomy and cord retrieval, chances of hemorrhages are more. So it's what is the abnormality on CT angio here? What do you see quickly? Here you can see this is the
right MC.
So you can see the right MCA, the whole right ICA is not visible here. This is the left ICA. So basically right ICA itself is occluded. So it's not the case. Okay. So we don't see right MCA also. This is a, so right MCA territory infarct. So basically occlusion of right internal carotid artery. Why don't you see any abnormality in ACA territory here?
ACA is being cross applied from the other side.
Yeah. So because the ACA territory is taken over by opposite side, so that's why we don't see any infarct. So now second, so 28-year-old postpartum 20 days. Okay, so it says 28-year-old postpartum 20 days, casualty presented with casualty, left hemiparesis and altered sensorium for 3 days. So what do you think it's a diagnosis? I've given you the clues. So whenever you look at a postmortem things, always, yeah. So basically you can see hypotension, some areas of hemorrhage. So there is involvement of basal ganglia, right thalamus. So can you think something?
Hemorrhagic venous infarct.
Yeah. So involving deep venous system. So when we see abnormality in basal ganglia and thalamus, it's the deep venous system which is involved. So what are the components of deep venous system? Intracerebral vein, vein of Galen,
internal cerebral vein,
vein of Galen.
thalamus veins,
Yeah,
basal veins of
this was a
Rosenthal,
case of deep CVT with hemorrhagic venous infarct. Yeah. So this is a case 3, 38-year-old lady, worsening diplopia, left hand weakness, slurred speech, progressive cognitive decline, dysarthria, whatever. So this is a 38-year-old. So what you see here, diffuse white matter abnormalities, small lacunar infarcts, involvement of temporal lobes. Can you think of some diagnosis? This kind of
Cadassil.
Yes, of course. There is one more entity called Caracil. You read about it. Like Cadassil, it's a Caracil. It's a case of Caracil. So should read about it. Okay. So quick. So it's almost a stroke. What is being performed here?
DSA.
So what is the procedure? So what is here? Right, MCA is blocked. We have taken some catheter. This is a procedure, mechanical thrombectomy. Mechanical thrombectomy. Oh, so here is a 60-year-old acute onset headache, vomiting followed by loss of consciousness.
And there is thick.
What diagnosis?
Maybe ruptured aneurysm.
Yeah. What do you see? What aneurysm?
MCA.
Yeah, right. MCA. This is a Sylvian fissure hematoma. It's in the subarachnoid space. This is a ruptured MCA aneurysm with Sylvian fissure hematoma and SAH. So spot diagnosis. Seizures.
Mesial temporal sclerosis.
Right, MTS. Fifth. So now, this is a 17-year-old boy, epilepsy, fast 5 years. So just I have showed some cases. What you can think of here?
DNET.
Yeah. So multicystic lesion, you can see. DNET can show enhancement also. So usually DNET can have associated cortical dysplasia also. When you're looking for a DNET, you should also search for adjacent cortical dysplasia. Spot. Gelastic seizures. Precocious hypothalamic
hematoma.
Here a progressive weakness in bilateral lower limbs. So whenever you see a spinal cord signal intensity, always, especially with a slowly progressive weakness, if you say long-standing history, always make an habit to see for any flowoids. You can see here on the dorsal surface of the cord, in the subarachnoid space, you can see some flowoids here. Could you make out?
Yeah.
See fuzzy. So what can be the diagnosis here? Okay, spinal vascular malformation, specifically a spinal dural AVF. So whenever you see a long-standing history, the cord signal abnormality, always look for this. This is a common diagnosis which is missed. So long-standing myelopathy, when you have a flowoids, so you should always think of a spinal dural AVF. So you should refer him for a spinal diagnostic DSA. This is a classical appearance of a spinal dural AV fistula with myelopathy. So what is this? Headache, loss of consciousness. What is the aneurysm here?
Basilar top aneurysm.
What is the procedure being done here?
Coiling.
Yeah, coiling. So basilar top aneurysm rupture. Spot T1, contrast T2. Bright on T1, it has bad saturation. It was a lipoma. Yeah, okay. So what is this abnormality? What is being performed? What is the procedure being performed?
Stenting.
It's a carotid stenting for carotid stenosis. What is this artery here? It's just marked. Something is marked. It's normal only. It's an anterior cerebral artery. What is this? The yellow, white arrow?
Sinus.
Which sinus? Straight sinus. Straight sinus. Okay. Just it's a spot. Look at here.
Horcrux sign.
Yeah. MSA C.
MSAC.
Yeah, done. Oh, this is one. So I don't give you rapidly progressive dementia. When you see that history,
CJD.
yeah, look at this. Look at this diffusion weighted images, bright caudate, bright thalami. This is cortical gray matter. This is CJD. So, yeah, this one. Right focal seizures for 18 years. Can you see something? Right seizure, you have to look for a left side.
Subcortical white matter hyperintensity.
Yeah, you can see here. What is this? Transmental sign.
Mantle sign.
Yeah, it's a classical.
Focal cortical display.
Yeah. Okay. So it's okay. Difficult for you. Leave it. This is bilateral thalami, hypodensities, infarcts. Have you heard of artery of Percheron infarct?
Yeah.
Yeah, this is classical artery of Percheron infarct. HIV patient. I have one more case to show. That's it. We'll finish. HIV patient. Yeah, it's a toxoplasmosis. Can you say something here? What do you see here? Very gyri compared to this normal. Sir, here can see.
Patchy, poly.
It's a polymicrovaria. Very small gyres. Okay, I think I'll stop. So last one. This one. I don't say anything. I'll just pinpoint the abnormality. Here. Now you can see something. Just case of seizures. The multifocal, cortical thickening, white matter bands. And I'll point one more here.
Tuberous sclerosis.
Yes. This is SWI. You can see calcified subependymal nodules. It's a tuberous sclerosis. This one. Seizures.
Status.
Bilateral medial temporal hyperintensity, hippocampal hyperintensity. It's an autoimmune encephalitis. Okay. I think I'll stop. It's getting over. It's okay.
And it was a really wonderful discussion. You have lot of cases, and you have the ability to teach also. That is very important. It is getting late. That's why anyhow we
I'll stop here. We can
will be one of our faculty for Kerala IRIA. We'll be inviting you again.
Definitely, I'll take classes for them also, like any specific topic.
It was a wonderful talk. Wow. So I thank you for presenting such a wonderful case discussion.
Yeah, sure. It's
Dr.
very
Venu?
Yeah. Same thing. One thing, just one word: fantastic teacher and a fantastic students.
Yeah.
I was just wondering that the student, they actually, I don't know whether they are residents or senior residents.
No, they are residents only. They are residents of Calicut.
So they answered almost all
the questions.
I'm really surprised actually. They are very well read. Very well read.
They do very well also in the department.
Very good.
Yeah, I'm very happy. The way of presentation also very nice.
Yeah.
So they picked up certain findings. So it's very well at MD level. I'm like very happy. Both of them presented very well.
Okay. Thank you so much.
Thank you so much for calling me for this on this platform. Really, very nice to know all the people here.
Okay, Reshmi.
Yeah, so thank you, Puneet. You are a really wonderful teacher, no doubt in it. Because the way you are teaching, because we know that like you continue teaching, like you are not worried about the time. That's what we felt.
No full stop. No full stop.
Yeah, no full stop. It's always a teacher.
Actually, I thought of showing more and whatever. I still had many. At least in a short span of time, just to stimulate them, just to know about the.
Really, I thought you will be finishing full neuroradiology.
Correct. It is wonderful. So thank you so much, Puneet. As
Okay.
Gomadi ma'am said, we'll invite you for more sessions. Please to come and do more sessions for us. So thank you so
Definitely.
much, and thank you. And the residents, Dr. Dharmin and Dr. Arya, both of you really did a wonderful job. The presentation, the way you presented, the approach, everything was wonderful. And Arya, that it was almost spot on for all the spotters. So very well done, Dr. Arya. And I thank Dr. Gomadi ma'am, Venu sir for and all the other office bearers of IRIA for conducting these academic sessions. We are doing it non-stop for the last 6 months. We are actually reaching the 50th academic session. So all credit goes to Gomadi ma'am and Venu sir, Ramesh sir, the program coordinator. So thank you so much. And all the attendees, thank you so much for participating. Do attend our sessions. And thank you, Soumya, so much for all the technical support. You are always being wonderful. So